present here, and welcome back to your favorite channel on understanding cancer, Cancer Reach. Cancer Reach is initiated by our very own tumor master, Dr. Krishnamani, to spread awareness about cancer and help caregivers and patients to access the right treatment at the right time. Without much further ado, let me introduce our tumor master so we can start diving deep into today's topic, that is decoding NGS. Dr. Krishnamani is a renowned medical oncologist with over 10 plus years of experience in the field of oncology. He has extensive expertise in treating all types of cancers, solid as well as hematological malignancies. Although he is a full time clinician, he also has a keen interest in research and has participated in various clinical trials. Currently, he is working at American Oncology Institute in Hyderabad. A very warm welcome to you, sir.
Hi, hello everyone. Welcome to Cancer Reach.
So, sir, today's topic, decoding NGS. Can you give us an idea of what NGS is?
So, this is a very new topic. New in the sense it's always evolving, and there is a lot of work which is going on. It's not exactly by new. We don't mean that it's just been there for 6 months or a year. No, but it's a kind of a tool which is getting refined. So to put things very simple, NGS means next generation sequencing. Okay, what is it? It's a test. It's not a treatment. It's a test. It's a test which is done on the tumor to help you give personalized treatment. So now we see in oncology personalized treatment. That is, you are going to treat people based on certain tumor characteristics he or she has. You're not going to treat everybody like a whole. So NGS helps you to achieve that. And that we will discuss in the next 30 minutes.
So, sir, NGS is helping in cancer diagnosis, prognosis, or treatment. Like, where does it stand?
So everything, actually, everything. So what is NGS? As I said, it's a test which is done on the tumor tissue generally. Okay. Sorry for my health, my voice. It can also be done on the blood, but more commonly it is done on the tumor tissue. So on the tumor tissue, you do NGS testing, or it is also called CGP, complete genomic profiling. So you look at the entire gene of the tumor. You look at all the DNA of the tumor. You try to find certain mutations, which are called actionable mutations, at which you can give a specific medicine. So it is diagnostic, it is personalized, it is molecular testing, it helps you give treatment, and that treatment has prognostic implications. Unlike chemotherapy, which blindly treats you without doing anything, which kills the normal cell and the cancer cell, here you are looking at individualized treatment, which will only kill the cancer cell and not the normal cell. And for that individualized treatment, you are doing a test called NGS to see if you are eligible for that or you have that particular mutation. You may have a particular mutation, somebody else may have another mutation, for which the treatments are different. So that is where NGS, or complete genomic profiling, it profiles the entire tumor genome. That is what we should understand.
Doctor, can you give us some real world examples of cases of this?
Yeah, two of my cases which come to my mind. I'll just tell you how it has changed their life. So we had a patient with stage 4 pancreatic cancer. Okay, it had spread to the liver. We started him on chemotherapy. Told the family, you have stage 4 pancreatic cancer. Treatment is chemotherapy. Most likely, he may not survive beyond 1 year. And the chemotherapies were very toxic, and he became quite sick due to the chemotherapy side effects. We also told them, let us try NGS on the tumor, because see, there is no other option apart from chemo. Your father is 73, 74, he's not tolerating chemo. Let us see if we have any other alternative to chemotherapy. We sent NGS. he has a BRCA mutation, which is seen in breast and ovarian cancer. And after the chemos were over, out of 12 planned chemos, he was able to complete only 10 because of severe side effects. His disease has come down due to chemotherapy. Then we put him on a tablet which you give for BRCA positive breast cancer because he also has BRCA. So basically, he has BRCA positive pancreatic cancer. But the breast cancer gene BRCA is seen in his pancreatic tumor. So that medicine, olaparib, which is given for that disease, has been given to him. Today, this February 25, if you enter February 2025, it is going to be 4 years. He's been on olaparib. He walks 10-15,000 steps a day, completely fit, and his PET scans every 6 to 9 months are completely normal. So what we thought he will die in 6 months. He's pulled on for 4.5 years without chemotherapy, with a tablet, because of personalized testing. If we had not done, we would have not known BRCA, we would have not given olaparib. So testing was done because there were limited treatment options. BRCA was found out and treatment was given for BRCA. And today his quality of life and survival is excellent. Okay, that is one example. Another example which comes to my mind is another 82-year-old gentleman. He had prostate cancer some 10 years back. The thing in prostate cancer is you have a blood test called PSA which increases. So whenever PSA increases, it means your disease is increasing. If you scan, the disease will increase. This man had progression on scans. He was not doing well. Scans showed progression, but his PSA was always low. So the PSA and the scan were opposite to each other. Normally, they should be same. The PSA rises, the scan also should become bad. Here, the scan is becoming bad, the PSA is going down. He received multiple set of chemos elsewhere, came to us. Then we had a doubt. By then, he had become bedridden, all chemo options exhausted. So we said, see, there is no relation with your PSA and your disease progression. All options are exhausted. You will not tolerate any further chemotherapy. Let us repeat a biopsy once. What is happening? Let us check. Because last biopsy was done 7, 8, 9 years back. We did a biopsy and we told him, sir, let us send for NGS because let us see if you have any options apart from chemo. He was tumor mutation burden high and microsatellite unstable high, which I'll talk to you, which is called TMB high, MSI high. Any tumor, if it is TMB or MSI high, immunotherapy works beautifully. So he was started on immunotherapy with a drug called pembrolizumab. 3 years today, completely fine, in remission, no chemotherapy, does all his work by himself, and no side effects. So both these cases illustrate that in desperate situations, bad cancers where you have little treatment options, where all options are exhausted, when you do NGS, you may find out something which is targetable. I'm not saying in all your 100 patients you'll find something. The pickup rate is increasing slowly. Now the pickup rate is almost 10 to 20%. So 10 to 20% of your patients may have something to target apart from chemotherapy. These are real world cases which has really made a difference in their lives.
So, sir, what I can reiterate is by personalized testing and by giving personalized treatment to the patient, the life of the patient has been prolonged. So, that is something which is very eye opening by a simple test. So, is it specific for certain cancers? Do you do it for all cancers, or is it only for certain cancers which you do?
See, this field is evolving. Lung cancers, we do a limited NGS. Are you able to hear me?
Yes, sir.
So in lung cancer, so lung cancer is one cancer with NGS initial days itself, 10, 15 years back, we found driver mutations. So in our earlier episodes of Cancer Reach also, you would have seen in non-smoker stage 4 lung cancer, we find a lot of mutations called EGFR, ALK, ROS, MET, RET, etc. So every patient of lung cancer stage 4, but more specifically women non-smokers, should have their tumor to be tested for these mutations. So NGS is done on lung cancer very commonly. We do a limited panel, 12 gene, 18 gene panel. And in non-smokers, if you find a mutation, you target with a particular tablet. For EGFR example, you give erlotinib, geftinib, osimertinib. ALK, you give alectinib. For ROS, you give crizotinib. These medicines work and they are indicated. They work better than chemo. Chemo is not required. So stage 4 lung cancer. Other cancers where NGS is done is limited panel is done in colon cancer. We do certain mutations called KRAS, NRAS, BRAF, etc. So there it helps us to choose targeted therapy. What kind of targeted therapy to be added to chemotherapy? Cholangiocarcinoma, where we do NGS. It's a bad disease. If you have certain mutations, you can treat it with those kind of drugs. And otherwise, so very commonly we use it in these 3 or 5 cancers. But in desperate situations where all options are exhausted, like I had discussed earlier, NGS is useful to help you take your patient forward.
So, sir, even within these cancers, is there any specific eligibility criteria for NGS testing that you follow within the specific cancers, like within lung cancer?
Lung cancer, it should be stage 4, number 1. Usually adenocarcinoma, but even squamous we can send. The pickup rate is higher in non-smokers and women. Okay, if you're a chronic smoker, you will do the testing, but you will tell your patient the chance of you coming EGFR or ALK positive is very less. Got it? In colon cancers, this is more useful for left-sided colon cancers than the right side of the colon. But still you test. And in NGS, understand a lot of new things are also coming up. Earlier, we just used to do, for example, EGFR, ALK, or RAS, etc. Now we do RET, MET, newer mutations, NTRK, MSI, TMB. MSI, TMB, PDL1 all help you for immunotherapy. Okay, in melanoma, you do BRAF mutations. So each of these mutations is specific for which you have a specific drug. You will start with a limited panel in some of these diseases. In certain other diseases, you do an extended panel. Extended panel is you can do 30 genes, you can do 100 genes, you can do 500 genes. The panel cost increases with the panel size. That is called whole genome sequence. So we should use our clinical judgment. Cost is extremely important. So many of the times what we do is we use a 160 gene panel, which is not that expensive also, where most of the genes are covered, like BRCA, NTRK, HER2, EGFR, ALK, etc.
Okay, sir. So, is it done only in fresh cases, or do you do it in recurrent cancer cases also?
So now some stage 4 colon has come, or de novo, or a new patient has come, stage 4 colon or stage 4 lung, you will do in them. In recurrent setting also we do sometimes because mutations change character. Okay, now rather than calling it NGS, now suppose somebody has had EGFR positive lung cancer stage 4, they are put on a drug called erlotinib. 50% of them, so at any point they all will recur. 50% of them, we will do additional testing and they will be positive for a mutation for which we change the drug, which is called T790M mutation. So there you will use a ultra limited panel. You will just do EGFR. What does it mean? Somebody uses erlotinib. After 1-2 years, if the disease progresses, you will do EGFR testing again to look for T790M mutation. Because if you are T790M positive, you will be put on another tablet called osimertinib. If you are negative, you will be put on chemo. So this is recurrent setting. You do it in the upfront setting also, like how we discussed, like lung, colon, melanoma, etc. I think there is some network issue.
No, doctor, nothing from. I will contact.
Are you there?
Yes, sir. You can continue, doctor.
Yeah, that's all.
Anything additional information you can proceed with.
So you can, for NGS, it is always better to have fresh tissue. Tissues older than 6 months or usually 1 year old and more, tissues we don't recommend NGS to be done. So at that time, what we would say is get a rebiopsy and send the tissue for NGS. So NGS is done in both new cancer patients advanced or in the recurrent setting. It can be done in the new tissue, fresh tissue or slightly older tissue, but not beyond 1 year. And you can do a very limited panel like in lung and colon, or do a very extended panel called whole genome sequencing. They look at 300, 500 genes, or somewhere in the middle where you do 161, 200 genes.
Okay, sir. So, sir, how is NGS different from the traditional cancer diagnostic methods which are used? And how is it different from the traditional treatment patterns which we follow in cancer patients?
See, 20 years back for lung cancer, the pathologist will only say it is small cell or non-small cell or squamous or adenocarcinoma. Based on that, your treatment used to go ahead. Now you say it is squamous or adeno. In adeno, you say whether it is EGFR or ALK or ROS or RET or MET, etc. So you are going into specifics now. You are no more sitting on the surface saying that it is just adeno or squamous lung cancer. Got it? So that way you are going into a lot of specifics in the molecular depth, and based on which you are deciding the treatment also. So now it doesn't matter if you have squamous adeno. You are EGFR, you receive one drug. You are ALK, you will receive one drug. ROS, you will receive MET, RET. PDL1 positive immunotherapy. We are no more bothered whether you are having, we are no more very strictly bothered whether you are having adeno or squamous. Same way, if you have colon cancer, especially left side, if you are RAS, RAF wild type, we say RAS and RAF mutation is not there, we add a drug called cetuximab or panitumumab to chemo. If you have mutation, we will add a drug called bevacizumab. Earlier, what used to happen, just give chemotherapy. Now on chemo, what drug has to be added, we decide based on the side of the colon, left or right, and whether you have RAS and RAF mutation or no. So your NGS is helping you to choose the medicine, give specific medication.
Okay, sir. And so when we come to talk about the costing for the NGS testing, so what is like the range of it?
See, it can be done from no cost to almost 4 lakhs. Okay. So now, for most of our patients who can't afford, especially the lung and colon panels, many of the pharma companies, what they do is they give coupons where the test can be done free of cost. Or else it is done at a nominal cost. An 18 gene lung panel cost maybe 11,000 rupees, which is very, very nominal. Colon panel can cost anywhere between 8 to 12,000 rupees. So 10, 15,000, you can get your NGS done, limited panel. 160 gene limited panel NGS, you can do it in India for as low as 35 to 40,000. There are multiple companies providing that. Multiple companies who do NGS now. So the cost has come down. 500 gene is expensive, costs anywhere approximately to 1 lakh. The same thing earlier, 3-4 years back, they used to send it to US. It used to cost around 2.5 to 4 lakhs. But now, with almost similar accuracy, you can do it in India for much, much cheaper.
And since most of our patients have medical insurance, is the testing covered by the insurance companies?
Unfortunately, testing is not covered by the insurance companies. Unfortunately. So they have to get it, independently. That is, if you want to get the NGS done, you come and get it under insurance. It is not. It's usually combined with their therapy. If you take chemo the same day, then maybe NGS is covered.
Okay.
Rather than that, excuse me, they should be able to do the NGS independently, cashless for the insurance patients, which is not yet done by most companies.
Okay, sir. And sir, as a clinician, do you face any challenges or any limitations to get NGS done for your patients?
Cost, number one. Number two, availability of fresh tissue. Pathologist will say the tissue doesn't have viable tumor, or patient is unwilling for a biopsy, repeat biopsy, or the area is so difficult that you can't get a biopsy. In that case, what you send is you send the blood for NGS, which is called ctDNA, circulating tumor DNA. But always tissue is best. So the cost is a major issue in India. That's why if you limit your NGS size to lesser amount of genes, you can get it done much easily.
And from the patient's perspective, are there any limitations regarding NGS?
That's what, see, suppose one is cost, even if they do, suppose they need immunotherapy, again, that is expensive. So cheapest immunotherapy today will cost you maybe 8 lakhs per month, 8 lakhs per year for the whole year. 8 lakhs in a year, that is almost 60,000 per month. Many people cannot afford. So what's the point in getting the test and saying that you need a costly medicine? Most people who have insurance can afford today, but otherwise many people cannot afford it. It is not in the health scheme. So those are the limitations. Once the immunotherapy molecules become cheaper, as the NGS tests have already become cheaper, then access will increase. Once medicine access increases, more people will start doing testing, because if they are found positive, they'll be given those medicines. In breast cancer, we do BRCA for everybody, most people. The BRCA testing is as low as 5,500, and the medicine is as low as 10, 12,000 per month. Very affordable. So that's where NGS plays a role. Eventually, cost will come down both sides.
And so, like when we talk about NGS, is there any alternative to that, except for the traditional biopsy methods which are used? Any other alternative to NGS?
Blood, circulating tumor DNA you can do, but that depends on the tumor shedding tumor cells into the circulation. So sometimes it may not shed when the time you're collecting the sample. That means that report can be erroneous. Those tests are also getting refined. So that is technically an alternative, like ctDNA we call it, alternative to biopsy.
And how accurate would ctDNA be, sir?
Not as accurate as tissue.
Okay.
But tissue also has its limitations. See, this is a very complex field. You say PDL1 positive, for example, in NGS. PDL1 is a very non-specific biomarker, we say. Somebody who has high PDL1, the medicine may not work. For low PDL1, it may work, because PDL1 may be different in different tumor areas. We call it tumor microenvironment. So this is very technical. So bottom line is, certain mutations are hard-hitting mutations. EGFR means you have EGFR. You will get the medicine, you will do well. ALK means you have ALK. You will do well with alectinib. Okay, RAF. If your RAF wild type means this medicine will work well for you. But the other ones, TMB and MSI means immunotherapy works and has very good high response rates, especially in uterine cancer. Okay, so, but for certain testing in NGS like PDL1 and all that, it is still, though it may not correlate with your response clinically. So just because on NGS you get this, don't think your patient will 100% respond. Take it with a pinch of salt.
Okay. And so, like when you say that the patient will not 100% respond, so does it mean that the NGS itself is having some sort of limitations, or is it because of the patient's response?
No, it is, NGS has limitations. The tumor is a complex area. One is, sometimes what happens, you see the liver will respond, the lung will increase. A patient has disease in the liver, lung, brain, bone. The liver will respond, but this tumor in the lung may increase. Why? Differential response. Some cells are responding, some are not responding. So you do NGS from here, you may get a different result. From there, you may get a different result. Got it? You can't keep doing NGS from every area every day. So every test has got its limitation. You are trying to do the best for your patient with available knowledge, and this will definitely improve over the next few years.
So, like if we have given the tissue for NGS today, How long does a patient have to wait to get the results back?
Your 12 gene panel and all will take 10 days. Extended gene panel will take around 3 weeks to 4 weeks.
So extended gene panel, when you say it is like the 500 gene profile or the
500 genes.
500 gene.
You did check for TMB, tumor mutation burden, MSI, microsatellite instability, etc.
Okay, sir. And sir, how do you see NGS impacting the future of cancer treatment going
It
further?
will be the future of cancer treatment. It's already the future. The present of cancer treatment, it will be the future. You will have better NGS, cheaper NGS, faster NGS, and more molecules will be based on NGS. More tumors will be picked up. Now, salivary gland cancers, we pick up NTRK mutation. Cholangiocarcinoma, we pick up NTRK mutation. We pick up FGFR mutation in cholangiocarcinoma. I said BRCA is seen in prostate and pancreas. Earlier, BRCA means breast and ovary. Now you say prostate and pancreas also. The same way, you are going to pick these mutations. HER2 is seen in stomach and breast. HER2 positive was seen in breast earlier. Now you say stomach cancer also. In HER2 positive cholangiocarcinomas or gallbladder also, you have HER2 therapy, which is given in breast cancer. So all this is because of these additional tests. They will really help. And time is coming where we are slowly moving away from chemotherapy after a point where we need these kind of tests to find molecules which will help the patient apart from chemotherapy.
So what I'm hearing is that there will be more personalized testing for the cancer patients and more personalized treatments which will be happening in the future because of NGS.
Definitely.
Okay, sir. Any closing comments that you would like to address the audience with?
I think we have already made that. NGS is here to stay. In a country like India, it is becoming cheaper. More people will have access. And because of that, they'll have access to treatment also. Understand that when you do NGS, in all your 100 patients, you will not pick up a mutation which can have a medicine. The pickup rate is 10 to 20%. But over the period of time, maybe it will increase. And the reason is you do NGS in common cancers as we discussed, but also in rare cancers where they are rare, you don't know what the treatment options are, or in patients in whom all options are exhausted and you want to find an alternative to chemotherapy.
Okay, sir. Thank you for a very interactive session. And I hope to see you next week as well.
Right. Thank you so much.
Thank you, sir. Thank you for your time. So we have stopped the recording, sir.
Okay, man. I think some technical glitch was there.